So let's learn about anterior uveitis. First of all, let's see what is uvea. You can see the structure of the eyeball here. So you can see the pupil, the cornea, the limbus, then the sclera, choroid and retina. You can see the iris. Behind that, the ciliary body has got two parts, pars plicata and pars plana. Pars plana, which is relatively avascular. Behind the ciliary body, you have the choroid. So, uveitis we can divide into anterior, intermediate, posterior, and total, that is panuveitis. Anterior uveitis means iris and the ciliary body behind the pars plicata portion, that is iridocyclitis. Then second is intermediate, so that will include, the next one is the pars plana portion, so that is pars planitis. And posterior uveitis means behind that you have the choroid and retina, so it is chorioretinitis. Clinical classification, so this is depending on the anatomy, which anatomical area is involved. Next, depending upon the duration, clinical classification, if it is less than 3 month acute, more than 3 month chronic, and recurrent means more than 3 months are taking between 2 episodes. Based on cause, granulomatous, non-granulomatous. So cause can be granulomatous disorders like chronic infection like TB, syphilis, like that, leprosy, non-granulomatous. So we have anatomical, clinical and causal classification. What is uveitis? It's the inflammation of uveal tissue. So it from iris to pars plicata of the ciliary body. That is actually we mean anterior uveitis. So anterior uveitis have, what are the different parts? One is just iris alone, iritis. That is predominantly iris is getting affected. Next, iris and the pars plicata is getting affected. What is called iridocyclitis. The next, only pars plicata predominantly getting affected. So it is cyclitis, anterior cyclitis, because it is the anterior portion of the ciliary body. Posterior portion is pars plana. Now clinical features. Clinical features, as we know, it's an inflammation. So there will be pain, there will be redness, lacrimation, photophobia, blepharospasm, defective vision. So regarding the pain, so when the patient comes, patient will say is having dull aching, throbbing sensation, and the pain is more during night. Also pain is also reaching up to forehead and scalp. Why? Because it is radiating along the distribution of which nerve? Of the trigeminal nerve. So radiating along the trigeminal nerve supplying area. So patient can have pain in forehead, scalp region, and when you look into eye, okay, patient is complaining as having redness, photophobia, lacrimation, all those things. Okay. So what are the factors responsible for defective vision in this uveitis? Why patient is not able to see properly? So one is due to the inflammation, there is spasm. Ciliary muscle is having spasm, so there is myopia. And then it is not transparent because the aqueous chamber, the vitreous chamber is not clear. Aqueous, you have exudates. Aqueous is turbid, and vitreous is also not clear. It's having exudates, and all those exudates can will not. They are not staying there quietly. They can close the angle of anterior chamber. They can cause secondary glaucoma. They can cover the pupillary area, exudates in the pupillary area, and all this can again be a cause for cataract. We know complicated cataract in which already the patient is having some intraocular diseases. Okay, so complicated cataract can occur. So all these are responsible for the defective vision in uveitis. Now the signs will be inflammation. You have lid edema. So starting from the lids, in the lids you have edema. Then you have congestion. So the congestion is actually congestion is divided into two, conjunctival and circumcorneal. So circumcorneal congestion is seen in two cases, uveitis and corneal ulcer. So here you can see circumcorneal congestion means from the center the vessels are radiating peripherally, center to periphery, branching pattern. They do not move with conjunctiva, do not blanch with phenylephrine, and they color is not bright red. It's almost like they are actually deep vessels, so the color is like a bluish red, like that. Okay, then what happens to cornea? So cornea will be having corneal edema. Whenever there is corneal edema, it's because endothelium has got some damage. So endothelium is actually maintaining the transparency of the cornea. In some case, whenever it getting in inflammation, endothelitis or any injury, all those cases there will be imbibition of the aqueous humor. Then what is the pathognomic sign of the uveitis is keratic precipitate. So there will be circumcorneal congestion, corneal edema, also there will be KPs. You can see in the center and the inferior part of the cornea, and these are actually the protein cell deposits. It's deposited below in the because it's settled down due to gravity, and it has taken a triangular shape. The apex is downwards and the base of the triangle up, that is Arl's triangle. You can see this. Sorry, the apex is above and base is below. That means according to gravity. So this is Arl's triangle, and you have got different types of KPs. What are the different types? One is small and medium, then mutton fat, then it is fine and old KPs. Small and medium is seen in non-granulomatous uveitis, and mutton fat KPs is seen in granulomatous uveitis, fine stellate and old KPs. Okay, small and medium is seen in non-granulomatous uveitis. It is actually composed of lymphocytes. Mutton fat KPs seen in granulomatous uveitis mainly have epithelioid cells, macrophage, large, thick, fluffy, lardaceous. They are having waxy appearance. Fine KPs, they are actually stellate KPs. So this fine will be covering the endothelium, seen in fits, heterochromic iridocyclitis and herpetic iritis. And old KPs is seen in healed uveitis. So it will be shrunken, fade, pigmented because it's old. And there will be posterior corneal opacity. Next, anterior chamber sign. Anterior chamber, you have aqueous cells. So they are the lymphocytes, all those cells, inflammatory cells. Aqueous flyer is the protein which is leaked from the vessels. Okay, so vessels having inflammation, increased vascular permeability, and all these proteins will be leaked into anterior chamber. So they are moving like dust particles are getting suspended. In the beam of light, you can see them as suspended. They have a motion, suspended motion, and that is Brownian motion, or we say Tyndall phenomenon, Tyndall effect. You can see in markedly this in non-granulomatous. Okay, non-granulomatous uveitis. And then in the anterior chamber, One is this aqueous cells, aqueous flare, then is hypopyon, pus in the anterior chamber due to the inflammatory exudates, inflammatory cells collection. Okay, hypopyon is getting collected. So you can get different types of hypopyon. Dense, immobile hypopyon. Hypopyon is dense and it's not moving. That is HLA B27, acute anterior uveitis. If it is cold, it is moving. So that is seen in Behçet syndrome. Behçet syndrome. And then it is hemorrhagic hypopyon. So HH. Hemorrhagic is seen in herpes and trauma. Called Behçet syndrome. So BC. Hemorrhagic is in herpes and trauma. Anterior chamber, so the shape can and the depth can change. What happens if there is posterior synechiae? It gets more deep and irregular. And in annular synechiae means all the pupillary margin of iris adhered into lens, so that becomes funnel shape. Now changes in the angle of anterior chamber, so there can be peripheral anterior synechiae, that means iris Bombay formation. The next is iris signs. So iris normal pattern and normal color is lost. So what is normal pattern is lost. What happens? There is inflammation, so the vessels in the iris getting congested, so that will be edema will be there and water logging and iris atrophy. Color is usually, it's brown. Here it is muddy color. Then iris has some nodules within it, that is Coppes and Busaka's nodules. Why these nodules? It is the aggregation of the lymphocytes and the epithelioid cells. So these cells were actually forming what in the cornea? Keratic precipitates. We know lymphocytes form fine KP, epithelioid cells, mutton fat KPs. Lymphocytes form small medium KPs and epithelioid cells mutton fat KPs. So in the iris they are forming nodules. Coppes nodules, they are actually in the pupillary border, and Busaka's means it is in the peripheral near the collarate, and they are large. Neovascularization of iris will be there, that is rubeosis iridis. Now posterior synechiae we told, that is iris and the lens. So what happens? The anterior chamber shape, what it happens, the depth will be increasing. Okay. So it can be segmental, means only at a particular point, or it can be in a ring shape, that is annular, or it can be total due to plastering of total posterior surface of iris can be attached to the lens. So if it is annular, means if it is in a ring shape, what happens? Occlusio pupillae and iris Bombay. So this is preventing the flow of aqueous from posterior to anterior. Iris occlusio pupillae means it prevents the flow of aqueous from posterior to anterior. So aqueous is getting collected behind, and the iris pushed forward, leading to peripheral anterior synechiae, that is iris Bombay formation. And segmental, you can see first segmental, a particular point only there is attachment between iris and lens. On dilating, it will have a festive paper appearance, that is festoon pupil. So that is one thing about pupil. Another is the pupil, there is irritation of sphincter pupillae because of the toxin released. So pupil will be getting narrowed. So why pupil is narrow? One reason is that irritation of sphincter pupillae by toxin. Another thing, the pupil is actually surrounded by iris, and the iris is actually very congested, edematous. So definitely pupil will be narrow. The vessels in the iris are engorged. Next, pupillary margin, there will be eversion, ectropion pupillae, due to contraction of fibrinous exudate on the anterior surface of the iris. So On the anterior surface of the iris, what happens? The pupillary margin of the iris, there will be eversion, ectropion. So the behind portion of the iris is actually pigmented. Now it will be coming to the anterior. Pupil reaction becomes sluggish because of the edema hyperemia of iris. Occlusio pupillae means pupil is all the exudates, this fibrinous exudates are deposited across the pupillary area, so pupil is occluded, that is occlusio pupillae. Then changes in lens, so lens pigments are deposited in the anterior capsule of lens. So here there will be complicated cataract, that's why you are getting breadcrumb appearance and polychromatic luster. So it is the posterior subcapsular opacities that you can see in the complicated cataract. Vitreous is not clear, have exudates, inflammatory cells, complications and sequelae. So as a result of this uveitis in the lens, you can get complicated cataract. Glaucoma can occur. Why? Early glaucoma can occur because these exudates will block the angle. Late glaucoma can occur because we told there is synechia. So seclusio occlusio pupillae, the pupillary block. Aqueous humor cannot move from posterior to anterior. Then next is cyclitic membrane, a membrane which stretches across the back of lens due to exudates. Then next is this inflammation can go to chorea, retina, choroid and retina, choroiditis. Then retina, it can cause retinal detachment, macular degeneration, cystoid macular edema, optic disc inflammation, papillitis. Finally, phthisis bulbi. So differential diagnosis, here you are getting a red painful eye. So red eye you get in many other conditions, acute conjunctivitis, acute congestive glaucoma, like then granulomatous versus non-granulomatous uveitis. So as I have told, this red eye features, how can you differentiate between these two? So in red eye, we know the one which is sudden onset is acute congestive glaucoma. Patient will having this all of a sudden. And the discharge here in acute iridocyclitis and acute congestive glaucoma, both you get lacrimation, watering. In conjunctivitis, there is mucopurulent discharge. Colored halos are present in conjunctivitis and acute congestive glaucoma, but it is absent in iridocyclitis. And then congestion in acute congestive glaucoma and iridocyclitis is deep ciliary, circumcorneal. Then acute congestive glaucoma, there is corneal edema. Iridocyclitis, there is mainly KPs, aqueous flare, pupillary exudates. And in glaucoma, IOP is raised. Along with that, patient will be having vomiting, headache, nausea, like that. Granulomatous and non-granulomatous, how can you identify this? See, mostly iris nodules will be present in granulomatous. So first of all, keratic precipitates will be mutton fat in granulomatous, small and medium in non-granulomatous. And iris nodules are present in granulomatous. Posterior synechia you can see mostly in granulomatous. Others are more in non-granulomatous, that is having an acute onset with more pain, more photophobia, more ciliary congestion. So all such symptoms are more in non-granulomatous. As a part of investigation, you can do a hematological examination, and we know the cause can be any disorder, chronic infection. So you look for uric acid value, test for syphilis, toxoplasmosis, histoplasmosis, MANDO, antinuclear antibody, LE cells, C-reactive protein. toxoplasmin test, then stool examination for such parasitic investigation, radiological examination, chest X-ray, paranasal sinus. So treatment can be local therapy. Atropine will relieve ciliary muscle spasm. Atropine will prevent the formation of synechia and also break if already synechia is formed. And atropine will reduce the exudates because it will decrease the inflammation, the hyperemia, vascular permeability, and atropine will increase the blood supply to uvea by relieving pressure on anterior ciliary artery. Then here is inflammation, so steroid, prednisolone mainly. Then broad spectrum antibiotics, systemic therapy, steroid, so pain, photophobia, all that. So you can give NSAID, immunosuppressive drugs. So photophobia is there, so you give dark goggles and hot fermentation for this inflammation. Specific treatment, that depends. First you identify the cause, treat the cause. Treatment of complication inflammatory glaucoma. If there is glaucoma, you have to give timolol, acetazolamide, Diamox. Then post-inflammatory glaucoma, iridotomy can be done. Complicated cataract requires lens extraction. Means cataract surgery should be done if cataract is formed. If there is a retinal detachment, you may have to do vitrectomy. Then if phthisis bulbi, we told that is the last complication, then enucleation procedure. All this should be done.